Good evening, everyone, and welcome to our session. I am Dr. Tarinee Puri on behalf of Voice of Healthcare, and I welcome you all to yet another session of Blue Wave of Change, navigating colorectal cancer awareness together, supported by Dr. Reddy's Labs. This series aims to raise awareness and provide comprehensive insights into various facets of colorectal cancer. Through a series of engaging panel discussions, we aim to address critical aspects such as early detection and screening strategies, highlighting the importance of timely identification and also discuss common misconceptions and barriers. Today, we will be discussing the shift in colorectal cancer dynamics and the reversal in trends. And now, I'd like to welcome our esteemed speakers for the day. Dr. Jitendra Pehalajani, Senior Consultant, Medical Oncology, HCG Hospital, Jaipur. Dr. Sushant Mittal, Senior Consultant, Medical Oncology, Action Cancer Hospital.
Good evening, everyone.
Good evening. Dr. Satyarth, Consultant, Medical Oncology, American Oncology Institute, Nagpur. Dr. Anup Toshniwal, Consultant Medical Oncology, Shree V-Care Clinic, Chhatrapati, Shambhajinagar. Dr. Toshniwal and Dr. Satyarth will be joining us shortly. Meanwhile, we'll begin our session. So, my first question would be to Dr. Pehalajani. Could you please explain us what the reversal in trend or the shift in the dynamics of colorectal cancer actually is?
So the point is, as an Indian subcontinent, a very warm good evening to everyone. So now we have many screening tool expertise available and expertise in the field of surgical oncology component, screening guidelines, as well as the newer therapeutic agents which are available. Now the point is how best we can use it in our Indian context that should actually guideline the shift because we are seeing more colorectal patients over the last decade or so because we are having an obese population more because now we are working less, so we are getting more obese population. Means earlier we used to have around 5 to 15% population which are obese that were only in the city. Now everybody is having high fat diet, so probably we are having 30 to 40% patients who are obese. So these all things are leading to more colorectal cancer, other cancer as well. So we have to see the blue wave change as well as whatever coming into us in the bad form and whatever best we can do with the available resources.
Right. Thank you, Doctor. Now, my next question would be to Dr. Mittal. So, are there any specific age groups or a specific sex that gets more affected in this reversal of trend? And if so, what are the key factors that contribute to this reversal in trend? Yeah, could you elaborate on that?
So nowadays, we are seeing a younger population who is presenting to us. And the younger population has a specific variety of carcinoma, which is known as signet cell carcinoma, which is little tough to treat because it is little resistant to the chemotherapy. However, we don't have any specific treatment just for signet cell. We use the chemotherapy agents which are for the other adenocarcinomas as well. So this is one of the shift which I have been noticing. Second, the earlier we used to see advanced stages, but now since as Dr. Jitendra was telling, because of the screening, because of the awareness, because of the uh, newer technologies of screening, we are seeing younger population. As per gender, I wouldn't say that male or female. I would say that they are equally at risk. However, because of the robotic surgeries or better radiation techniques, we are able to give them better treatment, to the sense that in molecular pathology, so much development has happened that in rectal cancers, which is part of the colorectal disease, studies are coming up that just giving the TNT, that is total neoadjuvant therapy, followed by chemoradiation, surgery may not be required for these patients. And with the advent of immunotherapies, we may be able to defer surgeries. But these are still in experimental basis. As of now, the chemotherapy, radiation, or surgery, all three modalities are required in treatment.
Right. Thanks, Dr. Mittal. So, as you mentioned, robotic surgeries. So, would you like to elaborate more on that, and even on the fact like how technology is helping in maybe early diagnosis, in screening, or a treatment you've already mentioned? But could you elaborate more on that?
Is it directed to me?
Yes, Dr. Mittal.
Yeah, yeah. So, yeah, the newer technologies in the screening, I would say that the stool occult blood is a gold standard and the colonoscopy, but newer scopes which are able to identify or negotiate through the strictures are better available to us. Secondly, in the biopsies, we are doing molecular testing, MSI, PDL1, and KRAS, NRAS, NTRK. So NGS panel, what we are doing helps us to know what treatment modalities needs to be given along with the chemotherapy. Third is the robotic surgeries. Robots, many hospitals are buying, many institutions are buying, but the training is required. The surgeons needs to be aware as where are the limitations, where are the advantages of the robots. Definitely surgeries in the pelvis where the movement of the hand cannot be as it can be of the robot. So in pelvic surgeries, definitely robotics have advantages. And in radiation technique also, lesser normal tissues are being damaged. The targeted radiations helps us to achieve the radiation what is required for the tumor kill. So these technologies in all the level, radiation, surgery, medical, molecular, all of them have helped to change the treatment scenario in colorectal cancers.
Thank you, Dr. Mittal. So, my next question is to Dr. Kumar. I wanted to ask you that since you mentioned obesity as a factor or a cause for this reversal, so would you suggest any dietary changes, lifestyle changes to prevent colorectal cancer as well as during the treatment?
There are two parts to this question. See, this diet what we are taking is basically what makes us from 3 kg to 60 kg, what we are as an adult. As a child, we were 3 kgs. Whatever we eat, that is part of our body for whole of the life. So, having said that, whatever we eat is important for us in a longer standing time. For example, if you eat more fat in the form of whatever the Western food we are having, like pizzas, high fried food in India diet also, like red meat. These all things are having the bad glucose, which is so called is very troublesome for our chronic diseases like heart diseases and some cancers like breast cancer, colon cancer. So these things actually harm us more. Number two is the amount of preserved food which we are eating nowadays is probably leading to, because colorectal cancer, or rather than early malignancy, uh, 15 years back when we used to study those, they were thought of these diseases are due to aging. Only few cancers which were genetics. But now, over the last decade or so, we are seeing patients having the disease at an early age. So probably somewhere the external exposure what we are having to pesticides or some external chemical or sedentary lifestyle. So these all things are basically causing it to happen early, means 10 years early in the population. Having said that, we should always use a balanced diet. What a balanced diet consists just in the crisp, you should have at least half of your weight of your food should be from vegetables or fruits, and whatever fresh you can have, you're from local vicinity. It should not be like that you should eat the exported fruits. That is not going to help, because that contains some amount of pesticide or preservative in it. Somebody is importing something from outside, that will not be that much fresh. If you see, second things, the fat should be minimal. It should not be zero, it should be minimal. And third thing is that you should have a adequate protein amount in your body. Along with that, a healthy lifestyle should also consist of a better daily activity, at least 45 minutes of exercise, whatever you say, 9 to 1 rule, 10,000 steps, at least 45 minutes in a week for 5 days. You should walk or you should do yoga as per as your body's requirement. And during the treatment, we usually suggest patient a healthy diet, whatever similarly is there. But since on the chemotherapy, on the surgery component, patient has more acidity, GI problems will be there. So we say them that you should eat small amount of food so that they can eat more, and it should have high protein in diet. So diet is definitely important, and we should always eat whatever fresh is available. I want to add a few things like in the newer paradigm, we are using CTC in stage 4 cancer. Means although it's not, it is on the horizon. Probably 5 years down the line, we will use CTC, means circulating tumor cell in stage 4, so that we can change our treatment or we can modify our treatment intensity, or we can assess, understand the disease more better. Having said that, and one more thing, that now NGS is so freely available. Means 7 8 years back it was 2.5 lakh rupees of a test. Now you can get it done in Indian labs, which are almost at the same standard, at almost the cost of one fourth, 50,000 and 60,000. They are doing good tests. So now technology in India is on the booming, and probably we will help more patient better. But having said that, prevention is the best strategy what we should have.
Thank you, Dr. Kumar. So, my next question is to Dr. Mittal. So, as Dr. Kumar stated, that prevention is the best way to go ahead. So, and we already touched upon early screening and diagnosis. So, what's the landscape like in India for early diagnosis and screening awareness, their programs, and how do patients take it? Are they aware? Are they actually aware about, even especially the younger population now, aware that they need to be, screened for it and what tests they should be taking, etc.?
So, as Dr. Jitendra rightly mentioned, dietary habits is one of the thing for prevention. The question you asked me is the early diagnosis and what awareness is there in the society. The awareness is that patients or people, normal population, if they have any bleeding while defecating or passing stools, they should consult a doctor. Most of the time, it might be just piles or it might be fissure, but you should consult your doctor and get yourself evaluated, because many a times I would say that Dr. Jitendra would also agree. Patients come that they had piles of fissure and they were showing to uh, some quack, and he was giving some treatment. He was not responding, and ultimately turned out that there was an ulcer which was malignant, and they come to us in the later stage. So it is better to get yourself evaluated by a scientific doctor, by a proper doctor. May not be allopathic, maybe Ayurvedic, maybe homeopathy. That's a science which is also practicing. So get yourself evaluated from a qualified doctor. And if it is not improving, meet a gastroenterologist. They'll just put in a scope. It hardly takes 10 minutes, and they'll see whether there's an ulcer. If there's ulcer, they'll take a biopsy and they'll let us know. In majority of the patient, it is not cancerous. It is just an infection, inflammation. But if it's cancerous, if it's in early stage, maybe just this little bit of surgery can cure it. They may not require surgery, or they may not require chemotherapy as well. So first and foremost, if there's blood in the stools, if there's a pain, if there's an alteration of constipation and diarrhea, in few weeks of the month you are constipated, then few weeks you are having diarrhea or loose motions, then again constipated. So this alternate cycles, that is change in the bowel habits, is one should be aware and get yourself evaluated. Third, if you have a smoking history or a tobacco history or high intake of alcohol, then, and if you have such symptoms, get yourself evaluated. Fourth, if you're having fatigue, initially you were able to take two flights of stairs, but now you are not able to take it. Just after one flight of stairs you are feeling breathless or anemic, then probably you have anemia, hemoglobin is low, and you are bleeding from somewhere, or the disease is there which is not letting your body function properly, and you're having fatigue, loss of appetite, or pain. So these are the early signs and symptoms for which patients should get evaluated. In India, we don't have any screening guidelines. We follow a Western guideline or a Japanese guideline, which tells us that after 50 years of age, every 2 years, you need to get a colonoscopy done. Or if you have a first degree relative who has a colon cancer, then 10 years prior to that, suppose the patient had 50 years, then the relative should start evaluating themselves at 40 years of age and get them done. In Japan, what happens? After 50 years, your insurance will not be renewed unless until you get a colonoscopy done. A screening colonoscopy is required to renew your medical insurance. Then only it would be done. So such kind of guidelines are there in Western population. We are trying and adapting the same guidelines for India. However, lot of more awareness is required right now for such early signs and symptoms.
Thanks, Dr. Mittal. So, as you mentioned, patient history playing a role in screening early diagnosis. So, I wanted to add a question. Are there other genetic factors that also are related to like colorectal cancer at an early age, or maybe even at a later age?
So yes, in about 5 to 10% of the population, it can be genetic. What it means that your father had or mother had or some other relative had, so that gene may be transferred in your DNA as well. So those are known as Lynch syndrome or FAP syndromes, or you have ulcerative colitis, or you have celiac diseases. So long-standing ulcerative colitis or celiac diseases are pre-malignant conditions, or somebody having a Lynch syndrome or a FAP, that is familial adenosis polyposis syndrome, then in those patients also one should get themselves evaluated by a genetic counselor. They'll make a pedigree of your family, and then they evaluate as to which test needs to be done, and you meet a medical oncologist or an oncologist, and they'll guide you as to what test needs to be done so that prevention can be done at the correct point. But this happens in just about 5 to 10% of the population. Nevertheless, if any first degree relative, such as your parents or your real brother or sister has, or your first cousin, such as bua's son or mausi's son or chacha's daughter, someone in your first degree relative has it, then get yourself evaluated at early stage.
Thanks, Dr. Mittal. I believe our other two panelists have also joined in. So I'd like to welcome Dr. Satyam and Dr. Anup to our session. A very
Yeah.
good evening.
Good evening.
All right. So my next question would be to Dr. Toshniwal. Um, could you talk about the stigma associated with the colorectal cancer, its diagnosis, and especially in the young individuals?
Yeah, so that's a very good question and very pertinent question, especially where I practice. Mine is a semi-urban practice. Some of the patients are urban, and most of them are from rural setting. What happens is the due to low socioeconomic status and due to issues surrounding cancers, most of the patients are very worried regarding colorectal cancer. That first, due to cancer, whether it is contagious. So, basic in rural area, if there is a cancer patient, people stop going to their house. They stop sharing food, water, even at place of their vocation. Most of the people who are employers, they try to fire the person who is being employed in that setting, and a patient has double hit in the sense that he has cancer, and then his source of livelihood also get compromised, and it is very difficult for patient to even start or continue treatment in appropriate setting. That is one thing. Second thing, there is fear of a permanent stoma or a temporary stoma due to surgery. A lot of patients are not ready to accept stoma, even though it might be life saving. They are hell bent because in rural areas and in low social status, it becomes stigmatic that the stool is coming out of abdomen. Sometimes there are leakages of the stool or gas. It becomes problem for that patient. Again, then there is issue of marriage for this patient. Even if after all this hardship, patient gets out of surgery, out of chemotherapy and everything, patient comes out, it becomes very difficult for those patients to get married who are on follow-up, because people start associating that the cancer might spread to the spouse, or the kids might have cancer due to genetic issue, and there is always a risk of relapse in these patients. So people from educated background, from high social background, this stigma is there when the society thinks too much about cancers. So this is how what I face day to day, day in and day out regarding these patients.
Thanks, Dr. Toshniwal. So, my next question would be to Dr. Satyam. Um, so, as Dr. Toshniwal just spoke about stigma, so to what extent that does awareness about colorectal cancer screening actually help in reducing, a late diagnosis, and does it actually really help despite the stigma?
So I'd like to apologize for the delay and for the poor quality of picture as I am in my car. So, uh, as far as screening is concerned, actually, it is virtually non-existent in our country because uh, uh, for something like colon cancer, I don't think anyone even counsels or anyone is even aware that there are screening guidelines. So I don't think that has to do anything with stigma. That has to do more with the lack of awareness. Uh, and yes, there are very clear-cut screening guidelines for colorectal cancers, and screening guidelines come up only if they have shown to be of benefit in terms of survival. Uh, like studies are conducted on general population, and if a screening test proves to be beneficial, it that is it increases survival, only then it is recommended. So yes, screening for colon cancer has shown to detect the cancer in early stages, and had led to increased survival in the population. Having said that, there are certain groups of patients who are at a higher risk than general population, and in them, like if the patient has a if a young patient has a very strong history of colon cancer, say in two first degree relatives, two either parents or siblings, they can be counseled, they can be offered proper screening they can be given proper screening recommendations as to when and what tests are to be performed for them. But again, as Dr. Toshniwal pointed out, majority of our patients, especially practitioners who practice in semi-urban settings, most of the patients are not very keen on uh, going for screening tests for whatever reason. Maybe it is associated with stigma, maybe it is associated with lack of awareness, or just a tendency to not be serious about matters related to health. So it is just a tendency that people in the lower socioeconomic status have. They are not very keen on things related with health. So yes, so screening currently is virtually non-existent. I think a lot has to be done in that respect.
Ma'am, you need to unmute yourself.
My apologies. Thank you, Dr. Satyam. So, we have a few questions from our viewers, and our first question is: are there any disparities or challenges in access to colorectal cancer care and treatment, and how can they be addressed? I would request any of our panelists to address the question.
So,
So let's her take question that question.
so there are, as we have seen that now expertise is available. Still, there are many disparities in form of one. Primary care physician are not having awareness that yes, malignancy is a truth and patient can have malignancy. As Dr. Mittal has alluded, that patient will be bleeding for 2 to 3 months or more than that, and then later on they will come with an advanced disease. So, having said that, patient should have the thing diagnosed. It's not like that ki 90% or 95% time it will be hemorrhoids, but if it's still, they should go to a qualified doctor and they should get it diagnosed. So, not getting diagnosed is the first hindrance in getting the patient early. Number two is the fear of stoma, as alluded by. But otherwise, I think by tier two cities we have expertise available. Maybe we are not able to do robotics in tier two cities, but yes, the basic class one care. Which should be available across India is now feasible and it's doable nowadays. And now it is not that much costly also because expertise is available easily. Now we have surgical oncologists available, radiation machines available at tier 2, tier 3 cities. So now access is not an issue. I think where we all are finding trouble is the awareness part. So the awareness is mandatory, and at HCG we actually trying to bridge the care gap, which is the theme of the 3 years of World Cancer Day awareness. So we are routinely doing at our Jaipur center speak program for screening, community awareness programs, what to screen, when to screen. And we have seen that although not for colon cancer people are coming, but probably for prostate and pap smear people are started turning up. So now there is a change because 10 years down the line when I was doing an graduation or post graduation, one in a society would used to have malignancy, but now we are seeing that everybody knows somebody who has malignancy. So now people are thinking that we should aware what is happening on what is going on. But still, it will take time, and we as an oncologist, everybody from their part are doing a lot of effort by writing in print media, by giving lectures, and the websites like you are also planning to do the changes. But still, we have a long way to go. By treatment part, everything is available in India, which we should do, which we are doing.
Thank you, Dr. Kumar. Um, uh, Dr. Toshniwal, do you want to add anything to what Dr. Kumar said?
Yeah, so basically there are three Indias what I see. One is extreme poverty rural area, other is middle class tier 2, tier 3 cities, then tier 1 cities, rich affording class of patient. Lot of disparity in availability of treatment to these people. Basic surgery, open laparotomy with a proper surgery of proper lymph node dissection is also not available to lot of patients. And at the extreme end, centers like SCG where they do robotic surgery is an extra like extreme other end. Lot of disparity. What I personally think is how to address the situation of disparity of availability of surgery, of chemotherapy, immunotherapy, targeted therapy, radiation, genetic counseling, so forth and so on. all these things depends upon the stratification, geographical, financial background of the patient. The patient, obviously, the government is also trying to help. There should be a standard of minimum standard of care which has to be offered to all of the patients, like NCCN provides low resource setting and normal setting. And the people who are at hilly areas, suppose islands like Andaman Nicobar or inaccessible areas, they should be taken special care. They should be given subsidized treatment. People from poor background also should give subsidized treatment. And as doctors, we also need to think where to put resources. Obviously, a patient who are going to afford, we can offer robotic, but it is not for all and every patient. It is just hardly any difference in OS or PFS. I know what I remember from literature regarding robotic versus open surgery. It is just the loss and this blood loss and difference in the post-operative recovery period. So rather than government investing in robotic surgeries or a high-end drugs like bevacizumab, where OS and PFS is not much different, uh, we should be looking at the policy level where there is a lot of bang for bucks, and where there is more benefit of investing in the public health infrastructure. Genetic counseling, sorry, the screening is a distant dream. We do not, we are not able to cater to patient who already have cancer. Patient who can self afford, they should definitely go screening. They have a high risk factors or it is indicated.
Thanks, Dr. Toshniwal. Would either of the two panelists want to say or add anything to the other two panelists?
I think they have covered most of the point, ma'am.
All right. So moving on, our next question is, what advancements in one sec, yeah. What advancements in screening technologies and diagnostic methods have contributed to the detection and management of colorectal cancer? I believe we've already, even though we've covered this, Dr. Mittal has, and even Dr. Satyam. But would anyone of you like to talk about it? All right. Now, as we this session is more about awareness, I would request each of our panelists to mention one personal advice or one personal experience they had while treating a patient, or adding from their own experience to our audience, to our viewers. We'll start with Dr. Mittal.
So, one piece of advice for whom? For the colorectal
Our
cancer?
viewers, our viewers, for
No,
on the basis of colorectal cancer, or anything that you specifically experienced or noticed throughout your treatment, or maybe something you noticed in terms of diagnosis, anything you'd like to share.
so I would say that colorectal cancer is increasing in incidence in India. And as the advent of newer technologies, as I told you, in screening, in diagnosing, in surgery, in radiation, in medical oncology, molecular pathology, the treatment is possible. One should not lose hope. And newer drugs are coming up, which are giving a better quality of life and longer survival to patients. So one should contact their oncologist for the latest update for the treatment, and one should not lose hope and should not be disheartened. And as the government of India is coming up with newer and newer schemes, these treatment modalities are also affordable. One need not be worried about selling their home or their land, or to have not no finances. Various methodologies or various schemes are available through which these patients can be treated. But contact your oncologist for better understanding. That would be a take home message from my side.
Thank you, Dr. Mittal. Now, moving on to Dr. Kumar, would you like to share a piece of advice and experience?
See, nowadays we are moving away from the infectious diseases to chronic diseases. So a piece of advice to everyone that whatever you are eating, eat healthy. Screen yourself for various chronic diseases like heart diseases, dyslipidemia, and malignancy as per your age, whatever your primary physician or your expert suggests. These tests will get you the disease diagnosed early, and in early stages, the outcome is far better rather than the later stage, and it is cheaper also. So get yourself healthy, prevent the disease. If you are at risk, get it diagnosed early and treat as soon as possible. Thank you.
Thank you, Dr. Kumar. Now I'd like to move on to Dr. Satyam. Would you like to share anything with our viewers, an advice or an experience or anything other than that?
Yeah, sure. So, colorectal cancer is a common cancer. It's a common malignancy. It is not a rare malignancy. It is seen. As oncologists, we encounter this very frequently in our clinics. So, it is for the people, for the general population. I would like to say, lead a healthy life, be aware of the symptoms, be aware of the red flag symptoms that like blood in stool or a constant change in bowel habits. So keep yourself aware. You don't need to panic, but be aware of the symptoms. Do not hesitate to take medical consultation, medical advice with respect to these symptoms. Make yourself aware of the screening recommendations that are available. uh, so these are the general advices for general population. And if you know someone who has been diagnosed with not only colorectal, any malignancy, make it a point to take proper professional consultation, which involves oncologists, surgical oncologists, medical oncologists, or radiation oncologists. uh, Unfortunately, in our country there is a lot of quack practice that goes on even with respect to cancer. So it is very important to take that little advice given by an expert and by some quack sitting in the village might be the difference between a long fruitful life and death. So it's very important to take a proper advice from qualified oncologists. Uh, so these are the recommendations for these are the advices rather for the general population. Keep yourself aware about the symptoms, about the screening programs, and take proper consultation from qualified oncologists. Also like to add a small point about physicians, about general practitioners. They should also be aware about the red flag symptoms, because many a times I've seen that they tend to ignore some of the very important red flags, some of the very basic red flags that are often talked about, like blood in the stool or iron deficiency anemia in an elderly. So they fail to do a simple rectal examination or a colonoscopy or a blood for stool for blood. So these are the things that can detect cancer at an early stage. But somehow physicians write symptomatic medication, and the patient takes symptomatic medication for a few months and then gets diagnosed after around 5 to 6 months, when it is too late. It can be too late. So even for physicians and general practitioners, who are often the first point of contact, it is important to keep in mind the red flag symptoms of colorectal cancer so that an early diagnosis can be made. Thank you.
Thank you, Dr. Satyam. Now moving on to Dr. Toshniwal. Could you share a piece of advice for our viewers?
So all the panelists have told in very detail, and I agree with all of them. So just another thing what I find is right now the normalization of addictions. Like it is very easily it is shown in movies that everybody is having drinks, everybody is smoking. Smoking has become a sort of status symbol. The hero smokes. They drink casually day in and day out. um, that is what is cultural appropriation, if I remember it correctly. So that has to be dealt with. No amount of alcohol is safe, even if it is like one pack or two pack per week. That is very important. That message has to go to society. Unfortunately, people think it otherwise. Low alcohol might be beneficial for heart, but that is some bullshit. It was due to some Mediterranean study which has been negated after that, and even for heart now, alcohol is not seem to be safe. It is there. Second thing, what is very important, what is overlooked, is obesity. There's rampant obesity in middle class, upper middle class, and especially urban area, also in rural area, which are good, which have at least like not in extreme poverty. Lower middle class also, there's a lot of obesity. It is an silent epidemic that has to be looked into. Other than this, everyone else has covered most of things. So that is what is very doable in our Indian society.
Thank you, Dr. Toshniwal. We have another question. Does losing weight decrease the chances of colorectal cancer? Um, Dr. Kumar, would you like to take this one since you spoke about obesity?
Yeah. Since losing weight means you have to come to a normal routine weight. Your BMI in Indian setting should be between somewhere 18.5 to 23.5. Below it, it will be drastically bad for your body. Above it, it will be drastically bad for your body for chronic diseases. Chronic diseases includes diabetes, dyslipidemia, heart disease, and almost 8 types of malignancies. So definitely, if you are obese, means if your BMI is more than 25, you should always bring that BMI to the normal level, and that will definitely reverse the changes in your body. Not uh, in a single change, but maybe in a longer run, it will reverse all the changes, and you can be saved from the harmful effect like NASH or many other things.
Thank you, Dr. Kumar. There's one last question. Does treatment differ in younger and older individuals for colorectal cancer? So, would anyone like to take this question?
I'll just I might have to leave early, so I'll just answer this question first. Definitely, there's a lot of difference between young and older. Older, as the age increases, the fitness of the patient goes down, and we need to calculate the probability of life, how long patient is going to survive. A treatment in patient who is 95 years will definitely be different from a patient who is 20 years old. And patient, even if like 30-35 years, has severely uncontrolled HIV or is on permanent dialysis, is post transplant patient or an immunocompromised patient, even for that patient, even if two patients of same age, the treatment will differ. So there is a lot of difference depending upon the age and fitness of the patient.
Thank you, Dr. Toshniwal. Would any of our other panelists like to add to this?
See, all the cancers, although they come into a subset of umbrella like breast cancer, colon cancer, but at the end, an expert team will decide what is the best thing which you should do. That is what we call as a tumor board. And at that point in time, on the basis of various factors like size of the disease, lymph node, site of the disease, age of the patient, comorbidity, there will be a design tailored treatment. Depends on how he responds to the therapy. So it's not a simple one word answer. Definitely treatment changes with age. Everything will depends on whatever it going on. Like genetics is not there or not, left sided, right sided, many things are there. So it should be a tailored treatment done by a qualified team of medical oncologists, surgical oncologists, as well as a radiation oncologist. And some need arises, some other team members should also be included. So it's a tailored approach for all of the patients.
Thank you, Dr. Kumar. Now, with this, we would like to conclude our session for the day. Thank you so much to our esteemed panelists for this insightful and engaging discussion. Thank you for joining us. And I'd also like to thank our viewers and stay tuned for our next session of the series. Have a good day, everyone.
Good
Thank
day,
you.
good day.
Thank you.
Thank
Thank
you
you
so
so
much.
much.